Good morning, everyone. My name is Barbara Koenig, and I am a nurse and medical anthropologist. I work at the University of California, San Francisco, where I'm very honored to serve as the director of UCSF Bioethics on behalf of many people across that campus. I want to welcome you on behalf of UCSF, UCLA, and the California Coalition for Compassionate Care. On behalf of those three organizations, I'd like to welcome you to Sacramento and thank you for joining us to discuss and reflect on the first year of the End-of-Life Option Act in California. Our objectives are broad. First is to share knowledge and experience of the implementation of the Act, the End-of-Life Option Act in California, and you have all been selected specifically because of your background and experience. Also, we hope to better understand the experience of patients, caregivers, healthcare providers, and healthcare organizations, because so many groups of people around the state have worked very hard to develop policies, practices, and procedures over the past year. We also hope to explore a broader topic, which is how the End-of-Life Option Act fits into efforts to improve end-of-life care, or if you want to talk about it as care of the seriously ill, either way works for me, but in both of those categories, to figure out how to improve that care, which I think is a shared goal among all of us in this room and is a major agenda for the California Coalition for Compassionate Care, for many other organizations as well. And then finally, we hope to discuss emerging best practices, discuss and review them, including best practices for those institutions and providers who opt out of participating, as well as barriers to best practice, because we assume that there will be many barriers to best practices. Let me give you a tiny bit of history of this particular convening so you can put it in context. We all know that in the fall of 2015, Governor Brown signed the bill. At that point, we didn't know the exact point of implementation. It ended up being June of 2016. In my view, at that moment, we were experiencing what I called a bioethics emergency, meaning that no one really had policies or procedures in place, and the law passed somewhat unexpectedly. So with support from Kate O'Malley at the California Healthcare Foundation, my team at UCSF, in particular Lindsay Forbes, who helped with today's meeting as well, we got together a one-day meeting near the San Francisco airport in December of 2015. Many of you were in the room. Many of you in the room attended that first convening. And I want to offer special thanks to Drs. Elizabeth Zeng and Laura Petrillo, who are here today, who helped with or organize that effort. But at that point, we got together a group of people who were going to be faced with writing policies for their institutions, and we also brought together some quote-unquote experts from Oregon and Washington who had experience there. And it turned out to be a very useful exercise for individual hospitals and institutions, health systems that were developing their own policies. There are we made recordings of those sessions and provided resources on a website that was sponsored by UCSF Bioethics. And that continues to this day, and we will be augmenting that after this meeting today. We now have the experience of just over 1 year to reflect on, which is the purpose of this convening. So at a conference sponsored by the California Coalition for Compassionate Care, Kate O'Malley and her successor, Kate Meyer, asked me, Neil Wenger, I remember the moment we were in a big auditorium like that, and they came up to us and said, well, would you take this to the next step? Would you do something else? And they asked if it was time to reconvene key California stakeholders. And by stakeholders, I mean individuals in palliative care, ethics, hospice, the representatives from different health systems, such as Kaiser and Sutter, and policymakers. So we agreed, naturally, when funders suggest that you do something, it's usually a good idea to do it. So we agreed and began putting together the proposal that we then sent to those two foundations. how did we proceed this time? Well, we had a little more time. In December of 2015, we it was like a train moving forward. We were sort of building the conference as we were moving forward. We had a little more time this time. So we set up a large steering committee of individuals throughout the state. That was our first step, including an executive committee with representatives of UCLA, UCSF, and the California Coalition. And then later, we were also joined by Helene Starks, who you'll be hearing from later today. And to prepare for this meeting, as well as for some research projects that we're doing, we actually held 2 face-to-face meetings in June of this year, one in the north and one in the south. And then we traveled to the other. The full executive committee traveled, and we tried to listen to people from around the state to get a sense of what their needs were and what would be helpful at this point. And that led to many of the particular topics that are addressed on today's program. For example, the role of interpreters, et cetera. There were lots of very concrete suggestions. So today's convening is part of that larger effort that we proposed to the 2 foundations, and you'll hear a bit more about that tomorrow. But in addition to the convening, we're conducting 2 research projects. One is a survey of health systems in the state, and that's being run by Cindy Kane and Neil Wenger of UCLA. And then we're also trying to capture ethnographically. As I said, I'm an anthropologist, so I'm very interested in the actual voices of individuals participating, what they're saying, what the issues are. So we're trying to capture the experience of approximately 20 families via in-depth interviews, and that project is being led by Helene Starks of the University of Washington. So before moving any further in this agenda, I want to really thank the 2 funders who have stepped forward to make this possible and will be providing support for each of you in the room to be here today. And that is first the California Healthcare Foundation, and they've now joined forces with the Stupski Foundation to fund this convening and the 2 research projects. So I want to thank Kate Myers, who's here, and Eric Bacon, and Parag Gupta, who are all here today. So please join me in thanking them at this point. And I'll be thanking members of staff at the end of the day. But for the moment, let's start with the funders. So this convening, and we're calling it convening rather than a conference because we don't want to lecture at people. The convening is meant to open up a conversation. No one has the answers. We hope to bring people together, possibly initiating new research collaborations or the opportunity to share policies and the opportunity really to learn from one another. It's important to remember, and this is a placeholder, Judy will say a bit more about this, to remember that physician aid in dying has been a deeply contentious and divisive issue. Prior to passage of the law, just about everyone had strong opinions on either side of legalization. But now at this point, it is really vital that we all join together and figure out how the End-of-Life Option Act fits into the broader patchwork of care for seriously ill patients near the end of life. And we need to be aware of broad societal issues and concerns. And so we'll try and do both today. And this is meant to be an opportunity to advance that broader conversation. I'd now like to turn the floor over to Judy Thomas of the California Coalition for Compassionate Care, who will say more about the meeting ground rules, and then Neil Wenger from UCLA, who will do some introductions and set the stage. Thanks.
Thank you, Barbara. And thank you to everyone for being here today and to giving of your time to have this really important conversation. And our goal here is to create a safe place for a very rich conversation. A conversation we probably haven't had before at this level of detail and breadth. And while there are other states who have implemented similar laws, there's something different about it here in California and about the time that we're at. The diversity of California requires us, well, it's really opened up our eyes that this is not a law that just implements itself. It doesn't just become law and then everything falls into place. There's a lot of things that have to happen in a wide range of ways, including this impacts all of us, whether you participate in the law or you know anyone participating in the law. It's still finding that place for all of us to live now that this is the law. You're all here. We've really tried very hard to get a diversity of perspectives here, of a wide range of opinions, experiences, and perspectives. And we want all those voices to feel comfortable here today, that you all have value. And the more we understand all those different perspectives, the stronger the movement for quality end-of-life care in California will be. That respect for different opinions was built into the law itself. It was a fundamental principle here in California, and it would not have passed without that. So I just want to encourage all of us to be kind to each other, to try to be sensitive in the language that we use, to be respectful, but to also realize we're human beings. And sometimes we may say something that has an implied perspective that maybe we don't mean, or maybe we just want to be able to articulate that perspective. So again, we really want this to be a place that very deep, rich conversation of a wide range of perspectives can be heard so that we can have a better understanding of this law and what it means for us. We have a lot of content to cover, so we've built in a couple of things we're hoping that will help facilitate covering a lot of information. On your table, Barbara, maybe you could hold up one of the sticky pads. Everybody has a sticky pad like that. And we want you to use that during these 2 days to write down your hopes for this conference, for this convening, the hopes for this law or how it does or doesn't impact things, as well as concerns. And we're going to put up a flip chart, right? Oh, we're just starting them on the wall over there. Somebody, yay, who was the first adopter, has already led the way. So that's a place to, we're going to keep track of what people are putting down there as hopes and concerns. You also have on your table note cards. So when we have sessions, we have a lot of content to get through and a lot of different perspectives to hear. And we have some time for questions and answers, and there'll be 2 ways to address that. One is on the note cards. If you want to write down a question, we will be collecting those and giving them to the speaker or the moderator. We'll also have 2 microphones that will be running around the room for people who want to stand up and ask a question, a live question. Which also leads me to remind you that all of the general sessions are being recorded. We have our videographer in the back, and those general session recordings will be made available just as with the prior convening. So if you don't want to be recorded, just keep in mind where the camera is and don't stand up and ask a question. The breakout sessions may be recorded by the note taker simply for the purposes of note taking. That will not be put up anywhere. It's just for internal purposes. Also, we do have several members of the media who will be attending. All are part of the convening. And we have asked them to just attend as background information, or they could write about the convening in a general way. If they want to quote somebody or to reference you specifically, they are instructed that they need to get your permission. And we ask for the same respect with our folks on Twitter, that again, just share the information in a general way with people who are following us on Twitter. And you do have information. The hashtag is EOLOA convening. And for those who brought materials that they'd like to share, we do have a table in the back of the room by the window back there where you can put out any materials that you would like to share generally. Some people, I think, also brought materials that they wanted to share specifically in the breakouts. So there's 2 different ways, whether you want to do it in a breakout or directly with people, and then back there in that back corner. So again, thank you for being here today. We really appreciate your input and are really looking forward to the next 2 days. Now I'm going to turn it over to Neil.
Thanks, Judy. So I'm Neil Wenger from UCLA. My task is to make sure that we know who else is in the room with us. As Barbara and Judy mentioned, the goal of this was to get a heterogeneous group so that we can all learn from each other. The group that worked to pull this all together was Dr. Koenig, that you just heard from, Judy Thomas, myself, Cindy Kane from UCLA, who is here somewhere, Lindsay Forbes, who is keeping us on track over here, and Helene Stark. The steering committee was a broad group from both the North and the South, and they met together once to provide a background for this group. Members of the steering committee, can you raise up your hands so we can say there's space throughout the room? Thank you. I'm going to ask different groups of people to also raise their hands so we can see what kind of heterogeneity we have among us. You may fit into more than one group, so you get to raise your hand multiple times. Patients and families, people who feel that they fit into that group. So we definitely have many here in the front. Thank you for coming. And we look forward to listening and getting guided by you today. Physicians, a smattering, great. Nurses, social workers. Wow, this is really good. Spiritual care, clergy, people. Good. Interpreters. I know we have interpreters coming. Oh, maybe tomorrow. Lawyers. Ethics folk. I'm sort of one of them. Wow, a lot of ethics folk. Researchers. A lot of people doing research on this. Press. We have a few press sort of in the back. Other groups that I missed. Who did I miss? Psychologists. Psychologists. A few. Pharmacists, yes. How did I forget the pharmacists? How many pharmacists are there? A few. Good. Public policy people. Oh, a lot. Very neat. Other groups that I missed? Yes.
People representing the disability community.
People representing disability. Thank you. Good. A number. Good. Hospice and palliative care? Great. So as you can see, this is a very rich, heterogeneous group of people, all of whom are quite interested in many different facets of how the End-of-Life Option Act gets played out in our state. And we hope to hear all the different perspectives today. I think that there may be some people from Hawaii here too. You want to? Oh, good. There are actually many. Wonderful. Well, welcome. And I think my understanding is that you're here to sort of see how this is working in California, and we hope that you get a good perspective on that here from the meeting today. One aspect that I wanted to mention is that a breakout late tomorrow will be on handling the difficult and tough cases. The purpose of that is to hear the cases that you all are experiencing and to bring together experts to be able to talk about how they might approach those kinds of cases and learn from each other. If you have such a case, you might want to write it down on the flip chart and or approach me or, there we go, or Carl. Because we're going to try to moderate it, not that we have any expertise in this area, but to make sure that there is a lot of different perspectives about how to handle these tough cases that are cropping up around the state. I think that is all of the introductions. Did I miss anyone that doesn't feel recognized? Great. So we're going to go directly into hearing Tony Back. I'm going to introduce Dr. Back. Tony is a professor at the University of Washington and at the Fred Hutchinson Cancer Research Center. He co-directs the University of Washington Center for Excellence in Palliative Care. We know him as an expert in patient-physician communication. He is behind, or one of the founders of Vital Talk, that many of us learned from and use in teaching our colleagues and residents and fellows. He did quite a bit of work researching and understanding the implementation of the Death with Dignity Act in Washington. And some of his scholarly work actually guided the policies developed by many of the health systems in the room today. He's going to talk about framing the End-of-Life Option Act within the larger context of end-of-life care, and I can think of no one better to be able to introduce that topic to us. Dr. Back.
You're welcome. Thank you. You know, when I saw this letter from Jerry Brown about the implementation of the End-of-Life Option Act, I was actually really impressed by the personalness of it. That he's read these the pro and con material, that he read letters of people who support the bill, and then he says right here, in the end, I was left to reflect on what I would want in the face of my own death. I do not know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I wouldn't deny that right to others. And I was impressed because I think it's a rare moment when we get that level of personal feeling from one of our elected officials. And I was really impressed at the thoughtfulness with which he went into this. And so as I think about what happens now, you know, a year later, with the End-of-Life Options Act, what I wanted to give you was a sense of what I think the new questions are in this thing, because actually I think there is a way in which this issue has shaped the development of palliative care in the United States. So I wanted to really start by telling you a little bit about my perspective, because I think that's only fair. So, you know, you may know from my written material that I have mixed feelings about this particular practice, which I think of as a medically hastened death. You know, there are many terms out there, you know, aid in dying, physician-assisted suicide, medically assisted, you know, and they all have their pros and cons. But I got introduced to this when I was a very young oncologist, when a patient asked me, isn't there some way you can speed this up? And at the time, I really had no idea how to face this question, and realized that I had no mentor who was going to teach me how to do this. And it was really a moment of truth for me as a young oncologist when I would actually get this question a lot and realize that people were thinking about this much more than anyone had let on. And so that led to some of our first work in thinking about what patients ask for, right? So we started to research this before there was any legal anywhere. And it was very clear that patients were thinking about it and were asking doctors about it. Now, I have gone on record in one public article about being in favor of this practice. And you'll see as I talk the reasons I mentioned, but I actually think that from my point of view as a physician, it's very clear that the public has thought about this deeply with many different facets, and that a majority of the public has said, we think this is really important. And I think they are telling something to us in palliative care that we need to pay attention to. You know, I was recently in the Nordic countries. They were getting together for a similar kind of symposium because they are also struggling with the question of what to do. And as I was talking, one of the things that just made their jaws drop open was this whole thing about how much the medicine costs in the United States and the fact that patients would have to pay for that themselves. They were aghast, frankly. And it was one of those times when it made me realize like how complicated this whole thing is. So I am open to this. I have not given any talks for any advocacy organizations. I don't give any advice to advocacy organizations. I haven't advised any political figures. I have done some research that was funded by a private foundation. Vital Talk, just in the spirit of full disclosure, does receive some funding from the Stupsky Foundation, although not for anything in this subject matter. It's really for communication. And so I just wanted to be clear with you. So I am open to it. I have talked to many patients about it in Washington. I have written prescriptions for patients who have been through the process, and I have been present at a handful of deaths. I have seen this go really well, and I have seen it completely blow up. And it's interesting to me that I think this particular issue concentrates the extremes of what happens in the end-of-life care experience. And I think for that reason, it is incredibly instructive for all of us who, knowing some of you in the room, really want to improve what happens and the experience for patients who are dying. So I think that's what I wanted to say about my own background on this. So I really am here because I believe in the value of dialogue. I think there is no substitute for the kind of large-scale community conversation that you all are hosting with this. And so I salute you for convening this and being present for this, because I think it's a really difficult topic. So having said that, I was just interested in seeing who here thinks of themselves as was in favor of the legislation before it was raised. Would you raise your hand? Who was not in favor of it? Please look around. Yeah. How many of you have spoken to a person, friend or family or patient who's been thinking about this at some level? How many of you have, how many of you have been with a patient or a person who has actually received a prescription and wanted to go forward? Look around, because these experiences are important. How many of you have been with a patient who has used the medicine at the time they used it? How many of you have been present in an intensive care unit when that patient had a ventilator withdrawn who died later? How many of you have been with a patient who died at home with hospice? And how many of you, finally, have been in an emergency room when someone died of a car accident or traumatic illness? Thank you. Okay, so there's clearly a vast spectrum of experience here, and I think it's worth calling that out, because I think the way we cut our teeth, metaphorically, is really important in how we see this moving forward. So I'm going to talk about 3 stories. The first one is Alan and Petra. Alan is a patient of mine. He had metastatic colon cancer. He was a software engineer and came to me after he had treatment from another oncologist where he had had a cancer successfully resected. He had gotten treated with chemotherapy, but the chemotherapy had made him completely lose any feeling in his hands. And if you are a software engineer and can't type, that's a problem. He felt like he hadn't been monitored very well, and I actually think he was probably right. He had his cancer recur. He decided he really wanted to have very minimal anti-cancer treatment. He didn't want to have routine chemotherapy. And his oncologist told him that he should find someone else. So he, anyway, somehow found me. And I worked with him on what he wanted to do, and he was very physically active. He and his wife drove all over the state and all over the West Coast to go hiking. This is his wife, Petra. And here they are in Florence. This was during the last year of his life. And what he did with the last year of his life was go to hike all the places he wanted to go. And, at a certain point later, he ended up finishing the process, taking the medicine, having a really beautiful death at home with his wife. And one of the things she said to me afterwards was that foreknowledge had allowed him to spend the last year doing exactly what he wanted to do. And this was it. He was really worried that if things got too bad, that he needed to have a way out. Many of the patients I see think of this as more of an escape hatch than something for intolerable, suffering that's going on at the moment. But in the end, I think he just got really tired and really worn out and decided because of that was the reason. My own practice is I ask people to call me when they decide they're going to take the medicine. And so I've talked to almost all of my patients the day before or the day of they took their medicine. And it's really an interesting experience. His experience put into light for me this recent position paper by the American College of Physicians. You probably saw this, came out this past week. They re-looked at the legalization of physician-assisted suicide and came to the conclusion, that we don't support legalization, it is problematic. Blah, 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 you can imagine. And for many of the reasons that many of you can see, it's the same ethical discussion that's been going on for now a couple of decades. And I think Alan would have looked at this and honestly he would have laughed. He would have said, Doc, it's already legal, right? This issue, this question actually isn't the right question anymore. And I'm not sure how much more we are going to gain as a community by continuing to grind away at this particular question. So my challenge to you is, what are the real issues? Because now 86 million people in the world live in a jurisdiction where this is legal. 86 million people. It is not it's not a quirk of a small state like Oregon anymore. It is really going to scale, and what that means is that we have to go to scale in terms of what we need to do to support patients and families and to understand what is really happening with this phenomenon. And I would say that the studies, I think, help us only partially in that regard. There was a recent thing by David Kassane's group in Australia. They were looking at, again, issues of depression and demoralization in patients who had an interest in hastened death. I didn't bring the data because honestly, there are 200 patients in that study. And if I look at the number of patients in Oregon who really want to go through with this, that would be like one of their patients, right? So I am not so sure how much of that kind of empirical data really informs what happens for a patient like Alan, who is very clear about what he wants. And as this discussion has gone more public, the patient advocates have become more prominent in a very clear way, right? Brittany Maynard had a video that went viral on YouTube. Now her husband last week is in Vox saying, my wife chose to end her life after battling cancer. Now I fight for others. And, they look pretty terrific. He is a really good spokesperson. And what is so interesting about this, as I see this discussion in the public about how important this is and how interested people are, I see what I think is a growing divide between what professionals in palliative care are willing to take on, because many of them are very uncomfortable and feel very awkward about this topic, and what the public is talking about. And I'll show you in a particular way. These are Google searches in the United States between 2012 and 2017 for the terms euthanasia, end-of-life care, hospice, palliative care, assisted suicide. So you can see hospice is pretty high up there, right? But euthanasia and palliative care aren't that different, honestly, right? And assisted suicide and end-of-life care are like right at the bottom. Now, these are Google searches, so I'm going to tell you that I think we got to take this, data with a grain of salt. But if you look at purely at an index of what the public sees and how they are starting to get into this issue, it's kind of astounding, frankly. The idea that euthanasia, that blue line, would be a little higher than the term palliative care in terms of numbers of Google searches, it's kind of impressive. Now, if you go to the worldwide data, it's even more pronounced, right? So here's hospice, here's euthanasia. This peak correlates with the Brittany Maynard YouTube video, right? And end-of-life care and assisted suicide are way down here. It's totally a fascinating issue. And I think it really speaks to how do people get into the discussion of facing their mortality. And so I would submit to those of you who are clinicians in the audience that we need to think about this really seriously as a gateway kind of conversation. Talking about hastening your death for many patients in our society is a gateway conversation. That's number one. Number two is the story of John and Robin. This is a public story. I don't know how many of you saw this story in the New York Times. Did you see this? John Shields was a social activist in Victoria in British Columbia. He developed amyloidosis. He also got a very severe neuropathy, and he was followed around by a reporter who actually did an extraordinary job capturing how he arranged the particulars of dying as he got close to the end. His wife, Robin, June Hood, at one point says, I just want to go into the woods and cry, and he's wanting to talk about having a party. He called an impromptu kind of going away party. a couple of days before he decided to use his medication. He actually in Canada had, I would say, like astoundingly good end-of-life care. He had home care, he had an inpatient hospice. Nobody was talking to him about you can't be an inpatient because you don't have refractory symptoms, none of that stuff. He had seamless care. And at the end, he still wanted to do this. And you know, the tableau that they show with him getting chicken from a local restaurant that he knew when he was a young man and all his friends is unbelievable. And there is an unbelievable podcast of him and his best friend talking to him. And his best friend actually can't even talk. He is so choked up. He spent most of the time standing outside the room. And when he went in, the first thing he said to John was, "I'm not going to say goodbye." It was an amazing thing. And I would say this kind of phenomenon, which I started to see as a young physician during the HIV era, when patients began to talk in a really widespread way about the idea of hastening death. This idea, which I'm going to call a choreographed death, is not actually new. I mean, it's been happening for a long time. But I will tell you that I have seen this with patients who are thinking about a medically hastened death to a far greater degree than than the vast majority of patients who I have taken care of who've died of cancer. There is something qualitatively different about it, and it is different not by a factor of 0.5, but honestly by a factor of 10. There is something really interesting about this whole phenomenon. And actually, I will say that this issue is starting to leak out beyond just the patient community. This was a recent commentary earlier this year in BMJ by David Nichol, who is a neurologist in the UK, and he said, basically, I've changed my views about assisted dying because when my old college friend was going to die, she called us all together. I flew to the continent to see her. We had an amazing day, and it totally changed my sense of what is possible. You know, when you get an invitation to this kind of party, it's not the kind of thing you turn down. You know, honestly, in our dispersed, divided, distracted world, this is the kind of thing that makes everybody slow down and stop and pay attention. And there is something really powerful about it. So I think this notion of choreographed deaths is, for many patients, I think one of the important things about this phenomenon that I think we could all honestly benefit from paying attention to. And actually, I have cancer patients who have learned from other patients who were their friends who had these kinds of endings. The third story I wanted to say is a different guy, also a public story. A little bit of a mixed bag. This is the story of Randy Stroop. He was a logger and commercial fisherman in Oregon. He was diagnosed with prostate cancer at a time when he had no insurance. He managed to get himself onto the Oregon State Health Plan and honestly was probably lucky to be living in Oregon. He worked with an oncologist who wanted to start him on an experimental medication, like, you know, the cutting edge, the thing that he had just seen at ASCO. And Randy was all excited about it. He tried to get his insurance to approve it, and the Oregon Health Plan said no. Not only did they say no, they sent him this letter that said, here are the alternatives. They include supportive care, pain medication, in-home care, medical equipment, palliative services, and physician aid in dying. Everyone went, holy cow, including Randy, who went right to the press, and it created a huge ruckus. You know, I know the people in Oregon. I know that the people at Oregon State Health Sciences were not the ones who were behind this letter, but this is an interesting example of the unintended consequences of this kind of law going into effect and being instantly translated into public policy in a way that I think no one really expected. And we have certainly done in Seattle some work with institutional policies, and I can tell you it's a lot of work, and it's really important to make sure that patients are accessing this in the way that you want them to see it as a patient or an advocate or a family member or a clinician, right? I mean, the thing that we are teaching over and over again is that a request for hasten death is really a prompt for goals of care conversation. And so in education that we have done, we have used, and this is, I'll put a shout out to Melissa Stern, who will be on a panel tomorrow, some work we did with Kaiser Northern California. Vital Talk developed this little acronym for responding to requests: listen to the reasons, elicit values and goals, augment the care plan, review the legal requirements, negotiate the next steps. It's a way to remind clinicians that they can't just start talking about the 14-day waiting period. They actually have to do all this other stuff first. And if you're interested in this, you can contact us later. We have not put this on the Vital Talk website publicly for a number of reasons, but we are going to put it in the next version of the app, which will be out in a couple of months. This is one kind of, adverse thing and one way of addressing it. I will say that there are many concerns about the effects on clinicians and family members. Remember I said I've seen cases that go really great and cases that go really badly. And one of the, I think, not so well studied and documented phenomenon is on physicians. This is a paper that was written by a radiation oncologist in Portland who talks about some of the adverse effects on physicians. And I can tell you that in one of our studies, there was a physician who took care of a patient who died at home of HIV. This was quite a while ago. Had a very powerful experience, and then was calling the family later to say, could I come back and sit in this room? It is beyond. And the family member said to us, eventually I had to tell them, please stop calling. Right? Clearly, there was unfinished business there in a way that I think is really, honestly, totally scary. Right? I have never written about this particular incident, but I mention it to you in this kind of setting because I think it is something. It says something about the power of an unregulated, unmediated, unsupported position of a clinician who went way out on a limb to help a patient and then realized they were really all by themselves, right? The physician in the story about John Shields, this is Stephanie Green, she's a palliative care physician in Victoria, has a really interesting viewpoint on this. She thinks of it in very practical terms. This is my job, I do it well. And yet the article acknowledges the impact on physicians. They talk about another physician who actually has someone else drive her home after a death, where they've provided euthanasia because it's so emotionally impactful. Now, I know there's going to be a family panel and other family members will be speaking, so I don't want to preempt them, but I just want to say that we have not really started to understand this very well. And the number of cases in Washington and the other places where it's been legal in the United States, I think are still, very small. So in my own mind, I think this practice is a kind of social experiment that we are still in the middle of. And one of the things I am starting to see in systems like the one Melissa has worked in are, intentional networks of physician connection that I actually think are really important and have not been studied or discussed or documented. And I think especially in the current environment that physicians work in, which is, there are a million things coming at you, there's a zillion kinds of administrative things you have to do. Physicians are more scattered and harried and burned out than ever. And I think in this climate, it's really, it's a danger point for us to introduce an emotionally potent kind of experience like this without much scaffolding. I will say that in the Netherlands and Belgium, there has been, unlike in the United States, a clear, slow increase in the use of euthanasia in particular. So this is Belgium. This is data from the European Bioethics Group. And you can see that there is a very substantial, very rapid increase in the use of euthanasia for end-of-life care. The more disturbing thing to me is that the people in Belgium don't really have a good explanation for this. Like, I was talking to a psychiatrist from Leuven, 2 weeks ago, and I said, what is going on with this? And he said, you know what? We really don't know. And that, to me, is a little creepy. And I think this phenomenon, which is you can see here, this is really something that we need to understand better, because I think there are potential unintended consequences about this practice. Those are the issues that I wanted to really bring up with you. I meant this to be more provocative than any kind of conclusion, because I know you're at the start of your day. And I wanted to say that I think that this dialogue isn't just about medically hastened death. It's really about the future of care for patients who are living with a serious illness, because the public's view of serious illness and what happens near the time of death, or what could happen near the time of death, has been so powerfully shaped by this. And so because of that, I think it's really important for us as a community to get a handle on this. I think for palliative care in particular, I don't think it's okay for us to go, no, that's not us. We're not involved with that. That is a recipe, in my opinion, for the public to go, palliative care? I don't think that's really what I'm looking for. There is something we have to figure out about how to talk about all these together. So that's my that's my 2 cents to add to Judy's for the work for the couple of days. I think it's very clear from my experience with this over the past 15 or 20 years that this is an issue that is not going to go away. When we published our first work about physician-assisted suicide in the early 2000s, people said, you know what, this is a flash in the pan. And I said, we'll see. And I think it's really coming back it's roaring back in a huge way. I could have never believed that the entire country of Canada would legalize euthanasia, right, with not that much public dissent, right? So, here we are. This is an incredibly rare opportunity to have a dialogue about this kind of work. And my things, in addition to Judy's, were to listen generously, speak from your heart, give everyone airtime, and be lean of expression. No, as my Zen teacher would say, no arias. So, with that, I am going to leave a few minutes open for questions, and I think I'm probably out of time anyway. Thank you so much.
So we have time for questions now.
Yes.
Thank you so much. So I'm Laura Petrillo. I'm flew in from Boston,
nice to meet you.
from the MGH, but previously from UCSF. And I want to thank you for those opening remarks. And I'm a huge fan of your work. I'm an admirer of, a lot of your writing. I've relied on it to think about this issue. I do want to point out, though, and just to acknowledge the breadth of perspectives in this room, it's not a foregone conclusion that this is part of medical practice and ought to be something that we accept because it's legal. Travel bans are legal right now in the United States. People are able to marry when they're 14 years old or need to have ultrasounds before having an abortion. There's all kinds of things that are legal that don't necessarily mean that we need to embrace them and fall into line. And so I think that given that here we are in California, it's perfectly reasonable to talk about how this affects our Californians in the state where it's legal, but in the United States, this is still being contested hotly in many jurisdictions. And part of the reason that's true is because of the plurality of experience that people have with end-of-life care and the heterogeneity of availability of quality end-of-life care. You talked about people who had excellent access to care and still were interested in this. You talked about some terrific-looking, healthy people, which is fine. But this is a law that would apply to every single person in the United States, or currently does apply to every single person in the laws in the states where it's legal. And we need to think about them, and you acknowledge these potential ramifications at the very end. And the Randy Stroops of society are the people that we need to hold in the forefront of our attention because we have a responsibility to them. So I just wanted to respectfully submit that there's that diversity of approaches to that in this room.
Yes, absolutely. Thank you for bringing that up. Yes.
Hi, Carl Steinberg. I just, that John Shields, that big New York Times hoo-ha, I read that too, and I thought it was well reported and so on, but to me, it seemed to kind of glorify the whole thing, and I guess I have some concerns that, that's going to become the new trendy way to check out, and that, throw a big party, and if you don't do this, you're somehow missing the boat. And I mean, so I just felt like it almost had a promotional kick, like something that Compassionate Choices would put out or something like that. Just your thoughts on that?
Yeah, well, so I will say, I mean, that is clearly, in many ways, a bit of a romanticized view, right? I totally get that is a romanticized view, and I think that it is only fair to call that out in that as a particular kind of thing. I thought what was notable about it was the depth of reporting that went into this, and actually the community that he assembled was quite remarkable, I thought. And I think those phenomena are worth calling out for us as observers and people who work with those kinds of things. The ability of him to call that community together to see him off in a certain way, there is something really powerful about that. And romanticized or not, I think there may be something for us to learn in it, even if we decide not to say this is the new standard we would set. Of course, long years in hospice that has been totally burned by this notion of a good death. We have to be really careful about what's the reality of care. And I think Laura's comment in some ways is the same thing. What happens to patients who don't have access, who have been struggling for any kind of care all along, and then you get this letter that says, this is one of your options, right? That no one thinks that is good, and the reason I talked about that story was because it's kind of outrageous in a way, right? So I think there are clearly both sides of it here, and of course I raise this here as a provocative point for us to think about. Not as anything that I think is the thing we ought to hold as the new standard. Fair.
I'm sorry.
Yeah. Sorry.
Yeah, Lonnie
sorry. I didn't
Schafelson.
see you. Oh, hi, Lonnie. Gosh, we've never met. I've heard a lot about your work.
And yours. I just wanted to piggyback onto that conversation and your point about the 5 times better deaths or whatever it was. My experience at the bedside now with 57 patients actually at the bedside with them is that these are routine deaths, not special deaths. That when it really works well, it's just kind of a wife and a couple of folks, or a son and a couple of folks, and that they actually are not traditionally highly choreographed. They start looking very much like all hospice deaths, but they happen faster. So I'm not sure we're in any special category. We can be. I mean, knowing the date and time of your death is a very unique experience. It is palpably different, and
Yes.
I think you're all right about that. But I think I want to make some argument that these become and should be they're deaths. And sometimes I have to walk into a family and stop for a second and say, let me just remind you all, you've been so focused on aid in dying because it's so hard to get there that you forget that somebody's dying.
Right.
And let's back up for a second. This is a death. And so, I think I'd like to see this more routinized. The press and everybody else, of course, in anything in the world takes extreme examples. But I think it's probably more routine than everybody's thinking. So,
Thank you. Yes.
Dr. Back, thanks for your talk and for showing us the stories of the people who used the Death with Dignity law. In your review of the media reports in the popular press, did you or on TV or internet or whatever, did you come across any stories about people who asked their physicians about death with dignity, but chose instead to live with dignity and have a good ending? Did you see any stories like that?
Oh, so there are quite a few stories, and there is lots of anecdotal experience that I and many of the other physicians in this room have, of patients who are interested in this beginning, do a lot of research, suss it out, and then decide not to do it.
Well, the question is, have you seen those stories in the press?
So there are occasional stories about them in the media. There aren't that many. And I would say that, in relationship to the issue here, I think that issue is not one that's come out so much, but it's not completely absent. So, I'm pointing these out as provocative examples rather than, any kind of clear sample of what's happening. But clearly, the different kinds of stories that happen as people start with this issue and then actually move to other things, I think those stories actually haven't been played out very much. And certainly, I have loads of experience, as do many others, with patients who thought this would be really important, and then it turns out realized that it's totally in the background, not something that they wanted to do, not something that they needed. Something that they could have, something that they could not make use of. So, but I don't know. I don't have any empirical figures in terms of media coverage in mind. Steve.
Tony, Steve Penelot from UCSF. Thank you for your wonderful comments. As always, incredibly thoughtful and really pushing us to think, which I really appreciate. Just two comment and a question. Just this idea of choreography, and I appreciate the comments around it. I don't think that these have to be linked, right? I mean, you can choreograph whatever you want about being sick and seriously ill and approaching the end of your life, and it doesn't have to be because I'm choosing a time and a date.
Oh, absolutely.
It just has to be about recognizing, right, and seizing that moment. And maybe
Yes.
those two things are linked, but it doesn't have to be at all. And not every person who undergoes aid and dying is going to have a big choreography. I think that was a great point. And not everyone who wants a big party, a big wake before they die, has to choose that. So anyway, I think that, but it is interesting how that could inform people in what they do.
And before you just mention the other thing, I think it's actually taking us back to death as a rite of passage, right? And there are many kinds of rites of passage, culturally determined, culturally shaped, personally shaped. And the question of us paying more attention to that, and actually what might be important about us paying more attention to that, I think is the question that this all raises in my mind. But
I thought the observation that the public seems to be ahead of the profession is a very important one, and I think that is true.
Yeah.
And kind of what the implications are, and I've certainly seen in California with the with the 2-physician rule. It's much easier to be the second physician to sort of confirm the diagnosis, and much harder to be the person who writes. And I think this idea of what the implications are for clinicians, it makes me wonder whether a way forward is to think about experts in this. And I think Lonnie's a good example of people who really embrace this, like people embrace palliative care or neurosurgery or anything else that we don't all do equally, because there is an expertise and a knowledge and understanding about it. And any thoughts you have about that? Because for most people, it's a pretty rare event.
It's going to be a rare event. So a couple of thoughts about that. The Dutch have now some experience with an end-of-life clinic that is actually there for the express purpose of evaluating people's requests. And I have seen some data about it. They have treated a couple of hundred patients. And it's interesting in that I think they have concentrated a kind of expertise. It's troubling in that it's like it seems like a totally it's like another silo for them that doesn't seem that connected to the rest of the care they're getting. And it does sound like, at least anecdotally, the Dutch situation is changing because the very strong system of family physicians who are in your neighborhood, who knew your family for years, who were previously the people who provided physician-assisted suicide. That sociology is changing in the Netherlands with this new generation. So I'm not sure if we know. Certainly there are some experiments going on with that, and I feel torn about it because on the one hand I feel like there is something potentially really important and powerful about the patient and family being connected to their existing providers, because most of my patients now have so many providers they're already bewildered, and so the idea of adding more is just daunting to me. And yet I get that there is this issue of what do we do for physicians who really just don't feel comfortable, who really feel like this is in their gut, they feel like this is the wrong thing to do. And how do we provide a system that allows for both of those things? And I think I'm not sure if I have an answer for that. Yeah, Ira, do you want to comment on this?
Ira Bayak from Providence Health and Services. Tony, with...
Uh-oh. Maybe I better not get too close to you, Ira. Maybe that's our feedback thing.
With great respect and affection, as you may know, I disagree with a number of the things that you said. A lot of what you described kind of characterized all of this in a more positive light than maybe you intended to. The public being ahead of the...
So I wish that I would meant to say, I don't think the public is ahead. I think they're diverging.
Right.
Right? But a little different than ahead.
And the idea of the choreographed death is beautiful, but haven't we slid a long way from the last resort to choreographed death? Isn't that part of the slippery slope? This notion, Allen and Petra wanted it, the planning for it. That's an important and I think a legitimate desire for people, but it doesn't seem like the last resort. But I'll get to my real question is, you've voiced the perspective of people who might want this and want to have the option, and put that in terms of, therefore, palliative care needs to be open to all of this. However, as a practicing doc, you know, and I've certainly seen many people who don't come to us or come to us very late because they already conflate what we do with hastening death, and they don't want it. And so we get the colleague says, I wish I could refer you, but they think that you're
too worried
and blah, 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 blah. And so I would assert first that from my perspective, this is beyond the bounds of medical care. So I actually think that ACP is right on in this. But palliative care would seem the exact specialty not to do this, so that the public has a true north, that they can come to us and we can give them the best care that we possibly can, knowing that we won't obstruct their access but don't participate. I just like your comments on the people who don't get voiced is the folks who are already worried about what we do.
Yes,
and
yes.
it's not a tiny fraction of the population.
Yes, no, I hear you. And so I totally get that there is something about people at large being worried about accessing palliative care because they think there is some kind of relationship to hastening death. And I think this is an open question, and I don't know if that I know the right thing. I mean, I guess my worry is that palliative care needs to develop some kind of relationship with this whole phenomenon because it's so big. You know, that's my real issue about this. I don't know that I am not advocating necessarily for palliative care to hold it or to administer it or be a routine consult. And in our institution, we made a very deliberate decision not to have palliative care do routine consults for this exact reason. So I do think there's something there. Is what we're gaining in educating the public about palliative care not being about hastening death, is what we're gaining by keeping an arm's distance from this worth it in terms of what we're trying to do with palliative care? And that's where I feel like I don't quite know. I am not sure. I think I am less convinced than you that keeping an arm's length from this phenomenon and this dialogue that is happening in the public, I'm less sure that that protects palliative care in some way. I actually think, my own opinion, is that palliative care will need to become the big tent for people who approach dying from a whole bunch of different directions. And, you know, we as a society have a ways to go to get there. So anyway, so I think I have a difference of opinion, but I have to admit it's only a hunch. I don't think I have much to say to back it up. The reason I just mentioned my caution is because I see among palliative care people a certain reaction to engaging with this topic, and I'm concerned about that. I totally would back up. I would totally back up that there are clinicians who should say, I see this is happening, I see it's important, and I can't do this myself. I totally respect that. But for palliative care as a field, not to engage in the discussion, I think is not good. So.
But engaging in the discussion is different than embracing it as an extension of palliative care.
Oh yeah. So I am not. So I am not saying. Yeah. And to be clear, I am not saying that this should be seen as an extension of palliative care. I totally get that this is a whole other step, and in the sense of thinking about it as a social experiment. That, in a way, is my way of bracketing what we are doing here as a society. So, but I think that's a fair point. Yeah.
Hi, I'm Marilyn Golden with the Disability Rights Education and Defense Fund. We too have a lot of concerns, a little bit like Ira there. It's hard to even know where to begin, but we're concerned that some of the media really focuses on the people who have access to the best care. And what about the ones that don't, whose stories don't get covered? Apparently, in the first year in California, 4 people on Medi-Cal took the lethal drugs, and yet it's not known whether they had access to palliative care, as an example. Randy Stroop is another example of what you said, and there have been similar examples in California of that. So we keep being worried about the kind of people the media isn't focusing on. In terms of a question, I wanted to, and there's so much more I could say, I don't want to talk too long, but I don't know, I wanted to see if you were concerned that, for example, in the Netherlands, I understand that you were alluding to trends there, but before that, were you concerned how for a number of years, documentation was clearly showing that something like 1,000 people a year in the Netherlands were euthanized without making a request, without their consent? And what does that say about where the West is going with this?
Yeah. So, there is this data in the Netherlands that there are public records about euthanasias that were performed without clear documentation of immediate patient consent. And at the meeting I was at, they talked about that a little bit. And I think it's clearly something where they recognize that something is wrong. That's not good. That is totally not okay. And I don't think anybody in the Netherlands or here thinks it's okay, honestly. And it is, I think, a red flag for the kind of public kind of policy and the structures that need to be in place to do this kind of practice in a way that the public can agree is safe and reasonable. And I don't think I would not at all question the sense that we as a group need to be willing to put in place those kinds of structures. And I think actually the people in the Netherlands, I think, are chagrined that that exists. And honestly, I think it was brave and honest for them to publish it. You can interpret that in a number of different ways in terms of whether it is for or against the practice. And, well, I mean, it just in the sense that they are doing it and that they are actually reporting data about it and the thing is going on. So I think in the sense of having an open practice about it, I think it is a piece of data about an openly reported practice. And I think they have a lot of concerns about the fact that that stuff exists and that practice appeared to be happening. So, there are, any time we have a procedure like this that operates at scale, I mean, I think there are ways in which we have to figure out what the bad outcomes are going to be and try to design around them. And I think there's no way around that.
I think actually we're going to have to go on to the next part of the session, but there'll be ample time to ask more questions. Thank you very much.